Good day, good afternoon, and welcome. Thank you so much for taking the time to join us for this very important discussion as we stand at a crossroads and reimagine Africa's HIV response. My name is Ines Kosana, and I'll be your facilitator. Today's dialogue is an official event brought to you by the Conversation Africa in conjunction with Georgetown University's O'Neill Institute for National and Global Health. It's the second time that they've partnered up to bring very important issues to the fore. This is the first to kick off the Conversation Africa's virtual dialogue series for 2025. Before we get going, I just have a couple of housekeeping and we'll get right into it. This discussion will be recorded and will be available on the Conversation Africa's YouTube playlist in the next few days. So if you know somebody that's missed the conversation, you can share the link with them. Secondly, we want you to be a part of the chat. So please feel free to drop your questions into the Q&A. And when the time comes later, we'll ask our panelists to address some of these. And finally, if you're joining this conversation on social media, please feel free to share your thoughts. Use the hashtag Africa Health as well as TCA Dialogues. Once again, thank you for your time. Now let's get into it. In 2013, countries around the world committed to a very ambitious target set by the United Nations Programme for HIV and AIDS. This was to end the AIDS pandemic by the year 2030. This year, with only 5 years to meet this goal, we find ourselves at a crossroads. The sudden withdrawal of the single biggest contributor to the global HIV response in January has exposed cracks in the system, and it threatens to roll back the massive progress made. And it's at this stage that UNAIDS and activists around the world are calling on countries to step up to transform their HIV responses. But what does this look like? To unpack this issue, I'm joined by an esteemed panel of public health experts, which I would like to introduce to you today. First from Malawi, we are joined by Dr. Beatrice Matanji. Dr. Beatrice has been the Chief Executive Officer for the National AIDS Commission in Malawi since 2023. She has over 15 years of experience in health program management leadership from mid to senior executive level. Dr. Beatrice, thank you very much for joining us. And with her today is also Dr. Charles Holmes. He is the director of the Georgetown Center for Innovation and Global Health, a professor of medicine at Georgetown University Medical Center, and serves as a distinguished scholar and program director at the O'Neill Institute for National and Global Health Law. Thanks for joining us, Charles. And from the Africa CDC, we are joined by Dr. Landry Tsage, who's the director of primary healthcare at the Africa CDC. He's held various technical leadership roles as the UNICEF Senior Health Advisor to the AU and the Economic Commission for Africa, and served as the coordinator for the UNICEF partnership with Africa CDC. Thanks, Landry. And also with us today is Florence Anam. Florence is the co-executive director at the Global Network for People Living with HIV. She's a global advocacy leader in the HIV response and primarily wants to see global policy and research decisions translate into implementation action. And finally, we are joined by Dr. Stephen Aisi Ado, who is the Senior Public Health Specialist and Deputy Director of Public Health at the Ghana Health Service. He's the immediate pause program manager of the National AIDS and STI Control Program in the country. Thank you all once again for being with us today. Let's just jump right into it. So there've been a lot of reporting on the impact of the funding cuts around the world. At least 2 countries in the room and a global NGO here in our midst. Let's take a few minutes to situate the conversation and get some first-hand accounts of how these funding cuts have been affecting different countries. Dr. Stephen, maybe we could start with you to briefly summarize what the status quo is in Ghana right now.
Well, thank you. Thank you very much. And good afternoon to good morning, good evening to all our audience. So let me put it in context. Ghana is, as far as PEPFAR is concerned, is a technical assistance country. What it means is that we did not receive massive funding, but they support through a cooperative agreement, and then also some support through the USAID funded projects. So in Ghana, with respect to the Ministry of Health, Ghana Health Service, the support was through for the strengthening of laboratory systems and HMIS systems to support the national response or antiretroviral therapy testing and all that. The second aspect is the support through the USAID EQUIP, which is supposed to be on-site support for improvement in the care of people living with HIV. And then we have other support for key populations and for stigma and discrimination. So the stop work order immediately, the funding cut, immediately affected all these to start with, because we were all supposed to halt all the activities. But later there was a waiver, and it made it possible for us to continue essential services. The Global Fund to Fight AIDS, TB, and Malaria supports treatment, antiretroviral medication. So it's not PEPFAR that buys medications for us. So that was not touched. But the activities which are linked to providing antiretroviral therapy were affected. So the EQUIP support is in 3 regions, Western, North, and Anhafo. And that came to a halt before there was a withdrawal of the stop order for partial, interventions. So all these, fortunately for treatment, we were still getting medication from Global Fund, and also the government of Ghana, because government of Ghana also buys medications. So to a very large extent, there was no halt in the treatment program. But what significantly was affected was the key population interventions for prevention and all the linkage services. So those were the areas that impacted it. And if you look at the Ghana model, it's a little different from the East African to a very large extent. Because of this co-financing already from government, it helped us to be able to absorb the shock, a little. But all the related services, in terms of the stigma, the mental health, all the other things were immediately stopped. But remember that all those services are complementary. And therefore, once there's a break, then there is a challenge. So this is what I'll say as far as that's concerned. Later, I'll come back with the interventions, what happened by our leadership, the immediate interventions to make sure that we avoid any break in services and all that. Thank you very much.
Thank you very much, sir. Dr. Beatrice, building on that, what has happened in Malawi? What's the situation there?
Thank you very much to you, our facilitator, and all people that are watching us right now. Similar to Ghana, we also have had disruptions to the services. And I must say that for Malawi, may be different from Ghana, that one was only getting technical assistance. Malawi's HIV services and systems are highly donor dependent. And our recent national AIDS spending assessment showed that less than 25%, around 22% only is the contribution from the domestic resources, with the rest being externally supported. So what this means is that once the external support or financing support dwindled or stopped, especially in January, February, when there was that stop work order that was sudden, there was a big impact on the services. The biggest impact area was the human resources for health, because over 4,000 healthcare workers of different cadres, especially testing and all other services related to HIV, were affected. Those that are employed by implementing partners of the donor-supported projects. Of course, when the waiver came, similar to Ghana, with the implementing partners that are implementing life-saving, what is called life-saving interventions, they resumed work. However, the numbers were not the same, and the numbers are still not the same. So this was a call to action and a very big lesson to us as a country, because we realized that even if they come back to work, We were not sure how long that would be. We're not sure how much that waiver would be. And therefore, as a country, the government stepped in to start taking more leadership. And I must say that there's been adoption of multi-pronged approach to sustain the HIV services. Initially, it was defining what is the essential minimum package that we can deliver with or without the partners. And those were the services that were delivered for a good 2 to 3 weeks before the partners had come back to implement a limited waiver. And so, in short, I would say that there's been an improved governance, domestic financing efforts, some improved service delivery implementation. That has been a response towards what had happened. But to give the context, we were heavily disrupted. The key population services are the biggest impacted because there's no waiver for them. And however, ART administration, testing among pregnant women, PrEP in the pregnant women and breastfeeding women never stopped because those were deemed as the least cost-effective and essential services. The other services were coming in later because after stabilizing and absorbing the shocks, there's been now, how do we sustain even more services? I'll come in more with the specific interventions that we took as a country. Thank you.
Perfect. Thank you so much. Florence, I would like to bring you into this conversation at this point. So Stephen and Beatrice have given us a country situation, but from your end, I'm really curious to know which population groups in particular do you think have been worst affected? And how have you seen, or where are the gaps in making sure that they are not lost completely?
Thanks, Ina. And I want to just start this speaking from my own person living with HIV perspective and representing our perspective. I think on January 20th or 21st, depending on whichever timeline you found this news and found the reality of what it meant for all people living with HIV, the world stopped. I think for the longest time, what has motivated testing and most of our community organizing has been the assurance that our treatment access is available. And for us on that day, this story ended. So since then, we are faced with the reality that there are mechanisms in place, yes, but there is an opportunity that our treatment access could be disrupted. I think for many, particularly young people who are not in the movement for a while or who do not know the history of the 80s and the 90s, there has been just this assumption. They don't even know what that looked like, or as some of us are scared about regression. They don't know the actual impact of it. There is another level of fear, particularly among young people living with HIV, that now comes with oh my God, we might get to see this world we hear about, but doesn't exist. I think the immediate response, particularly for those who are reaching to their health facilities and finding change, was panic and anxiety, and I think that is still there to varying degrees. The localized local person does not understand the different dynamics and the politics. So what's a waiver? What's this? What's that? They don't. They just see the news and then they see what's on social media. And there was a lot of misinformation at the time as well about what's going on. I think what I noticed very quickly, and I found that a little bit inspirational, is how the people living with HIV networks quickly rose up and connected with their governments at country level. I think that was the first and the immediate thing we noticed from our global GNP Plus side, as we started to convene each other to figure out what messaging, how many people, who's getting affected, what can we start to do to make sure that this doesn't end up in people stepping out of treatment. Because at that time, there was a lot of information around, oh, so this is the end of treatment. Also, what's the point? Some people started rationing, some people, which is a lot of people, ran to the clinic to hold because you don't know when the next supply will come, which then burdened the health facility. So there's a lot of confusion at the beginning. I think between January, February, March, it was a period of darkness for many of us. Community cadres that both Dr. Beatrice and Dr. Stephen have talked about, those that talk that include us in the work around community health systems, mental health support, peer education, community outreaches, testing, including point of care testing and early infant diagnostics for children, services for prevention to key populations. All these are held by communities. And this is jobs for them too. So those also got lost. I just want to quickly narrow down on what's happening now. I think as things settle down, there are certain realities of what's going on. Still, some people, I think this week, 3 organizations have let me know they are retrenching and reshaping and reorganizing. So there's that hit both to people in general, but also to organizations. As the adaptations go on and we are starting to be included into broader health services, there's a cost that's coming to services that were previously free, and that's starting to prove as a challenge for people. So there are various things that are happening both at personal level, at organizational level, and at livelihoods level. Yes.
Thank you very much, Florence. And Dr. Landry, finally, maybe you would like to add into that from the CDC perspective. What is the kind of impact that the CDC has seen, and what are you seeing that is being done as well?
No, thank you so much, Ina. I think listening to Stephen from Ghana, Beatrice from Malawi, and Florence, there's a clear illustration of how impactful the reduction of external funding to the HIV response has been in our countries. I think to put things in perspective, the continent, Africa, has seen a reduction of close to 70% of overseas development assistance between 2021 and 2025. So we have seen that gradual reduction, but what happened recently around December and January of this year is that abrupt interruption of some of the major donors or funders of the HIV programs. I think that abrupt reduction or that abrupt interruption is what has created the disruption that my previous speakers highlighted. There has been a lot of concern around continuity of services, and I think we advocated as Africa CDC early on for a establishment of life-saving services. I think the PMTCT program was one of the first that was established, as well as the treatment program for children. Around advocacy, I also want to acknowledge the fact that our head of state they came up quickly before even the disruption in January, February. Already in October, the president of Rwanda, His Excellency Paul Kagame, who is the AU champion for domestic financing, had already called his peers to look into how to set up sustainable financing for health in Africa with a view of increasing our domestic financing. So they met in February of this year in Addis Ababa, and they mandated Africa CDC and the other AU organs to rethink health financing in this new era. And I would like to invite you, if you can have access to this document, which is available online. It's a publication that came out as a result of the call from our head of state to rethink health financing in Africa, looking at this crisis that not only the HIV program, but the broader program that I've called it the broader investment that our countries were receiving for primary health care. I'm sure I think some of the statistics were shared. Close to 70% in some countries of the primary health care financing is supported by external funding. So this disruption is not only affecting the HIV program, but I really want us to understand that it's affecting the integrated package of primary health care interventions. So unless we leverage this opportunity to establish a much more sustainable mechanism of financing of our health system, which will leverage, first of all, domestic financing, because the Abuja Declaration, as you all know, few countries on our continent have met the 15% Abuja target of allocation of domestic financing, of domestic budget to the health sector. So that's the first area where our head of state wants us to emphasize more. And advocacy is critical. By doing that, we can also allocate resources towards the continuity of our HIV programs, as mentioned, the continuity of the workforce. I think workforce is a critical piece where domestic resources should take care of the workforce, especially in the case of Malawi, the 4,000 healthcare workers who were affected by this cut. The second point I just want to highlight, Ina, is around the new way of thinking on health financing on the continent. The second direction of travel is innovative financing. And I want to emphasize here on the fact that innovative financing, as we speak about it today, is really tapping into those pockets of resources that can build around solidarity, not only at country level, but also at continental level. Let me give you a few examples. The taxes that can be leveraged on air tickets on the continent, the one that can be leveraged on imports, those that can be leveraged on the, we may want to call it sin tax. I want to believe that if we collectively tap into that, the continent can leverage significant amount of resources even beyond what was coming through the ODA. What we are not talking a lot about is the remittance from the African diaspora. And for the African Union, the diaspora is considered the sixth region, or the AU considered geographically 5 regions, and the diaspora is the sixth region. And annually, the continent, through its diaspora, receives significant amount through the remittance. And 1% of that remittance is enough to fill the gap that we are facing around the ODA cut. The last point I want to make here is the direction of travel on innovative financing is also asking us to critically innovate in the way we engage our private sector, because the health sector on the continent is definitely one that can generate jobs and also generate revenue for the private sector. So how do we look at investment from the health sector through blended financing, through investment that will tap into the infrastructure, as well as areas like local manufacturing, which is definitely, for us, as far as HIV is concerned, I can come back on that, it's an area where Africa CDC is working with partners to increase the production on the continent of HIV diagnostics and HIV medicines. Thank you.
Thank you so much, Landry. You're opening a can of worms with that innovative financing conversation. Colleagues, the document that Dr. Landry was referring to, the Africa Health Financing in the New Era, we've shared a link in the chat. So please have a look, download it, peruse it, and engage with it. Thank you. And then moving on now, Dr. Charles, we'd like to bring you into this conversation and change things a bit and engage with how countries have taken the turn on this issue. As the funding cuts were happening earlier this year, HIV leaders from 11 African countries have stepped forward with powerful African-led responses. Can you tell us a bit about this body of work, what has been done, and why is it so important?
Well, thanks very much, Anu. It's great to be with you and this incredible panel that you've assembled. I've been really privileged to work in partnership with Dr. Matanji to help foster this multi-country consortium that has been brought together, known as the Sustainable Prevention Initiative. And it came together in the last year or so, but its roots stretch back actually 5 years ago or more to work that was co-developed with the Malawi National AIDS Commission and the Ministry of Health. So if I could just take a moment to describe that, and then I'll tie it back to the founding of this consortium. So the Blantyre prevention strategy that started about 5 years ago was an initiative that we worked on together with the government of Malawi. So instead of taking a donor lens, we tried to really flip things around and take a district and national level lens and think about what kinds of public health functions needed to be better embedded in districts and the national system in order to control HIV in order to drive more systematic community engagement and ultimately have a more nationally owned program over time, as opposed to one that was more fragmented and involved uncoordinated partners. So that was a successful endeavor and led to its expansion to the next largest city, the capital city of Lilongwe, where over the last year, both Blantyre and Lilongwe have been able to launch new prevention products, such as long-acting injectable PrEP, on top of and benefiting from this strengthened district level system that's really well coordinated at the national level. So it helped to put NGOs and other partners into kind of an aligned framework in which they were sharing data, collaborating together on quality improvement. And that idea has grown now, and other countries were interested and led to this Sustainable Prevention Initiative, bringing together groups together now with the Africa-led HIV Control Working Group. We had a meeting in Lilongwe in February, and that happened to coincide with the devastating US stop work orders. And so I think as the ministries of health and NACS, civil society, and others came together, there was a lot of information sharing and a lot of energy around developing an early vision on how to respond. I just want to highlight in particular a document, a policy document that emerged from that 2-day meeting that we can share as well, that really talked about the kinds of national leadership that could and should take place, referencing the Africa CDC continental financing strategy that Dr. Sagi just mentioned. And also to Florence's point, pointing out that we have to, in this difficult environment, protect marginalized populations that have often been looked after by more community-led responses that have been very quickly cut with the funding changes. So following that, we came together again in Kigali and had an outstanding day-long pre-conference, and actually led to a whole Lancet series of 6 papers, which are now in development. And we're looking forward to coming together at a high-level event at ACASA in Accra, in Stephen's home country, and really outlining further this vision for national leadership, for district leadership in this challenging time, but also a time of opportunity and forward-looking country-led responses, as opposed to more donor-led responses that had been successful in the past, but hadn't necessarily built the kind of direction that we need today.
Thank you very much, Charles. I think what's coming out really from this early conversations we're having is the need for country ownership of their programs, just to protect to protect some of the programs that are set up by donors. So as we move on to the next question, I have so many questions, but let's move on with this conversation.
Do you allow me to just interject one important point on what Charles highlighted as national leadership and country leadership? I want to also bring to the attention of our audience that recently the head of state of Africa, because at the end of the day, we need to understand the continent of Africa remains one of the highly affected by this cut. And when it comes to HIV, we still carry the highest burden. So if there's one place where the difference has to be made around leadership, it's in Africa. And around partnership, the Lusaka agenda, I just want to make sure that our audience get a chance to understand what the Lusaka agenda is calling partners and member state, our governments, around programs to do. They are calling us to be more efficient in the way partners supporting national programs. It's not only HIV, but this is applicable to all donor support to our national programs. It's about alignment around one country plan, one coordination mechanism. And this is where the leadership Charles is referring to becomes critical. And one reporting framework. And with that, the Lusaka agenda is also asking domestic financing to transition, because donor financing is not meant to be permanent or to be infinite. It has a lifespan. And our leaders are gradually or maybe affirming that around the health sovereignty in Africa. And I'm sure you think my brother Stephen can share more about the recent leadership of the president of Ghana, who called his peers to talk about the Accra Reset and health sovereignty in this new era. I just wanted to emphasize that point that Charles made. Back to you, Ina.
While you have the floor, Dr. Landry, I want to point to you. So what has happened in the immediate withdrawal of funding is that obviously countries have put together emergency plans, emergency funding, and other donors have stepped in. As we are doing this to bridge the gap, are we masking bigger challenges?
Can you repeat the question, Ina? You dropped a bit.
I am just asking that the emergency plans that countries have put together, do you think that they are sufficient to deal with the issues at the core of it, or are we just putting a plaster over cracks?
I think, let me just take a step back to say, when Florence took the floor, Florence highlighted the points that are critical, because what happens upstream at policy and strategic level cannot replace or should create the enabling environment for what happens at community level and what happens in our health facility or primary health care. I think Florence articulated the unique strength that the HIV response has shown over time. HIV response is one that has always shown creativity, courage, advocacy, and community-led solutions. And I think this situation the HIV response is facing on the continent is one where we are definitely convinced that emerging solutions led by community are going to meet what the policy and strategic decisions are already creating as an enabling environment. I was focusing on that one, but definitely at this level, there's a lot going on at countries level around the leadership of people living with HIV and civil society. We need to encourage that, and we need to create an environment for that to maintain continuity of care, ensuring that the most vulnerable are not left behind, and really creating the environment for our people, especially the young people, to overcome this storm. Thank you, Ina.
Thanks, Landry. Thank you very much. Beatrice, maybe we can pull you into this conversation. Could you give us some insights? Like, are we bridging the gaps? And what is it that needs to change? I think now we are seeing what's working and what's working, and where is it that these HIV programs and responses need to pivot?
Thank you. Maybe before I go to the general what needs to change, allow me to share what the government of Malawi did or is doing in order to not only manage the crisis that we're in, but also to move towards sustainability. So the first area is governance. There's been a shift from NGO-led or non-government organization-led or donor-led approaches to government of Malawi-led approaches. So as I said, after about 3 weeks or so, there was a call to return to work for limited waiver. However, no implementing partner started working on their own. The government came up with an IP or implementing partner cooperation framework, which every implementing partner had to sign to, understand, agree. And one of the key issues in there was whereby no NGO will deliver services without the shadowing of the government staff. So whereby previously, when implementing partners came in, they were taken as a relief, whereby the rest of the staff would say, okay, let's go back. Understandably so, because if you're in a health center, there's only 1 or 2 nurses, they have to do maternity services, they have to do everything. If someone comes and covers the ART clinic, that is a big help. But it has not helped the situation, because with the withdrawal, then it meant the ART services or the HIV services have to be closed because there's no one. So one governance issue was to start at every level, whether at national level or local level, the implementing partners had to align to providing technical assistance, mentorship and support more than being in the forefront delivering the services. It looked harsh. It looked like, are we going to deliver quality work with the fewer government staff? But it is the only way to make sure that there is the transfer of skills, because those IP staff now are transferring skills to the government staff. They're understanding they may not be here forever. And even the government staff are understanding that our partners may not be here forever, which was taken for granted before. So another thing on the HR, because who are they going to transfer skills to? Knowing the gap of almost 4,000 people, if this was permanent gap, then it would have created a very, very big void in the system. The government of Malawi allocated resources, increased resource allocation to the budget of the Ministry of Health. In January, February, it was towards the end of the fiscal year for Malawi, because the fiscal year starts on 1st April, which means budget ceilings and everything had already been developed. But there was a deliberate move to redirect and increase resource allocation towards the Ministry of Health. It may look small to others, but for us, it was a big change, because there was almost $600,000 that was allocated to the Ministry of Health to improve these systems, to recruit more health workers, to train the health workers, but also to improve like sample transportation, because we know viral load testing, as vast as and complex as it is, it needs, I would say, more focused and more deliberate move towards resources towards that. So the government of Malawi put in that money, but also co-financing. I think traditionally, like in Ghana, most of the HIV commodities, almost all, were coming from Global Fund, with some from others like PEPFAR and others. But the government of Malawi had very, very minimal, a very negligible % of co-financing. But from this year, that co-financing contribution improved by 650%. It moved up to 1 billion kwacha. It was the first time that there was an allocation and a commitment to co-finance up to 1 billion kwacha towards HIV commodities. And as I said, HR improvements, even the health information systems, it was almost, the EMRS was almost came to a standstill, because the people that have skills, the people that were leading, even the lab systems and everything were donor implementing partners. But now what has changed is that all those systems at every level, it should be a government person leading with the supporters, the implementing partners, supporting and building the skills, and also building the technical assistance around that. So I would say that this is what is needed, and we need more of a transition from donor dependency to increase domestic financing. We do know that even what Malawi government has put in is very small compared to the whole needs. But the government is not the only partner. We have the private sector. We have others. Can we all come together to improve the domestic financing? And the other issue is integration. I think what has been the biggest problem is that at HR level, at infrastructure level, and at every system building block level, HIV was taking a parallel and vertical system. Now the country, and this is what we're calling upon all countries, is to move towards integration. Even the sustainability roadmap that started last year, which was supposed to be launched by 1st of December, as almost like a donor-driven thing, at the work of what happened at the beginning of this year, we had to move in to change how that roadmap looks like, because the integration has to take a center stage. Luckily, the health sector strategic plan emphasizes on integration already, but I think what has happened has just kind of augmented the need for integration. And even the Global Fund, when they said we should reprioritize and move the funds towards essential services, integration was the key. Because you can't be going to the same community, one implementing partner, one program and another, doing different things in the same community, when actually they could have gone together and done the same activity. So integration at every level. And I'll talk from the National AIDS Commission perspective. We have a vast network of multi-sectoral structures that have been built over the decades in response to HIV. They've been doing nothing but HIV. We have the religious network, we have the civil society network, we have the, all the other networks that are out there. But already from last year, after our functional review, and when we had already foreseen that by 2030, things will change, we did strategic redirections to move towards expansion of their roles. So what we'd want is if an mpox comes today, and we know mpox or COVID or anything would affect those that have immunosuppression and chronic diseases more than everyone else, should the networks that are supporting HIV delivery not support mpox and COVID and other emerging threats? So integrating at structural level, at functional level, at service delivery level, and at every level is the key, and that's what we're calling for. Thank you.
Thank you so much, Florence. You're making such important points. Oh, sorry, Beatrice, my apologies. Florence, you are on my mind. That's why I'm misnaming people. I wanted to bring you in at this stage because you had mentioned earlier some of the ownership that communities of people with HIV have taken of the programs. What do you think is missing here?
I would like to answer your question and starting with also the first question, or are we closing the gaps, or are we, putting a Band-Aid on this? So I think it will sort of go together. I think we have to, I would like to situate this from something that Dr. Beatrice has said, and then something Dr. Landry also said. For the last, I think at GNP+, I will start from there. We had sat here looking at ourselves as people living with HIV with the running message from the global level being, we want to end AIDS as a public health threat by 2030, what that actually meant for us, what that would actually mean practically. And we had already seen that this would mean practically that countries will take ownership, that we will need to go and organize and mobilize ourselves at country level, that services would require then to be integrated, not basic. We hadn't even thought about transitions and funding. That was 2022. It was just basically people living with HIV in and of themselves are evolving. And we are having now integrated services for NCTs. We are having practical needs of people who are not able to go to different facilities. Stigma is still high. It's affecting how people are presenting for treatment. It's the young people telling us how they feel a bit stigmatized going into, single disease environment. So all of these things were happening. And in 2022, we started what we call the Future of AIDS movement as a way to sort of come together as community to shape what this would look like and prepare ourselves to bring this matter to the global leaders and ultimately cascade this at country level. And then we worked together with the leadership of UNAIDS and PEPFAR and Global Fund with our governments towards developing the HIV sustainability roadmap. So this was work in progress. And I think a lot of, depending on where and in what level, some level of community preparedness to something is coming and change will come has been sort of happening over time. What we had understood is that this will be a transition, and that whatever it is, integrated services, sustainability programs, there will not be a destination. There will be a progress and process as it goes on. And I think what we are facing now is some reality, a little bit quick and fast and like ripped apart, but we are in that change a little bit faster. And I think two things that we think here. I feel like, and I will say this from our perspective at GNP+, sitting here as people living with HIV, and we convene about 10 or 15 countries here and thereabout, and we convene people living with HIV every 2 weeks. I think there's a shock to the system, and the resulting experience is what we face. So there's this, tomorrow there's that. There is a lot of news that keeps coming up, and then there's a lot of all this noise that is reacting to the news. And I think this, on a personal level, affects us. And I just want to highlight that this affects us. There's, I think, January to about April, I don't know if you ever opened social media and did not understand how many people are expected to die. And I had to go into calls and say, guys, you're talking about me, you're talking about us, it's people. I mean, this can't be your leading narrative. Let's speak. And there were all these other beautiful emerging things that were happening at country level that are missing. So I think for me, there's aspects of narrative change that are needed now that will be able to take us ahead a bit, because I feel like we are sort of stuck in this. Something happened in January, when for us, because it's our lives, we are sitting in little groups and thinking, what could we do ahead? What can we do with our governments? We are really going back into our governments right now because we know that's where everything sits. And I want to say we are finding opportunities to engage. As people living with HIV, we are finding opportunities to engage. It's not that we have that much resources to engage effectively, but whatever we find, we are able to. But I think it's a small space currently just sitting at national level most of the time, just with governments. It doesn't cascade primarily at the global level, and maybe that's something that we need to look at. But we have innovative ideas. And that's where I'm leading a little bit to what Dr. Landry said. Things will emerge. I don't think now is the time to say we are making the change. Things will emerge, and a change is a process as well. So what we are doing now may not be what will be needed next year, and etc. But I think it's critical to understand that the emerging solutions will come from the patients, from the people living with HIV and those most impacted by HIV. So when we insist on holding on to certain institutions or mechanisms or things that must remain as they are, I think we sit here and we are a bit baffled because we know we've evolved. We know we are no longer in an emergency. We know some institutions were created in an emergency, and somehow our governments were in a different state at that time. I don't even think Africa CDC was as strong as it is now, but we see all of these beautiful opportunities that exist now. And if the African continent is the continent with the highest burden, I believe we need to have some Africa context-specific realities to its data, its opportunities, its ability to evolve and emerge, led by communities' lived experience, because our lived experience are naturally not concepts. They are realities that are really at proximate level. So that's that. So now to your question about which was what exactly, but I think I sort of answered it, but I don't know. But I just wanted to also add that for us, the integrated services has been because of need. And in terms of trying to do our best to sort of lead the discussions and the adaptations at country level, we've also convened ourselves as people living with HIV and are currently in the process of defining integration for and by people living with HIV, and looking at this as an opportunity to do one critical thing that we've also agreed we must do. Something about the government people talking has inspired this, and I must say it. We existed in parallel funded programs. All our community work was parallel funded, and we have to accept that this was an anomaly, or maybe it was needed at some point, but needed to have been shifted. So what's lost was not what was in this system, was what was not even in the system. So how do we bring it to the system? But primarily our advocacy, our engagement with governments and leaders and partners and donors has been operating from a mistrust, and that we have to build. And so for GNP Plus and the people living with HIV community, we are looking at this document. It's research in progress. We want to bring together ourselves and governments and other partners at ICASA in a dialogue that starts with a very systematic ask. For these are some of the minimum standards that would make integrated services work for us. So that is a way of also just activatively building trust, which I think is critical.
Thank you so much, Florence. You're such a sober voice. I must confess, though, that as a journalist, I am guilty. I was one of the people who was always asking, but how many people are at risk? How many people have we lost to treatment? So yeah, once again, thank you so much for bringing this voice to the fore. And it really is such a sobering take on a situation where we are all kind of losing our heads a bit.
I can't resist.
I wanted to.
Maybe after Stephen.
I wanted to come in to say something. Clearly, I mean, leadership is key. Leadership, political leadership, programmatic leadership, community leadership at all levels, very critical for this. But I think something that happened, which we also did during the period, which must be sustained, and it's in reaction to some of the things Florence has said, is the risk communication when there are challenges like this. In fact, in the world, there will always be some emerging challenges. When the crisis comes, even the way we manage it in terms of communicating with people is critical. We must have a clear strategy for communication. We needed to, in our context, inform the recipients of care of the interventions we were taking, the measures we were putting in place. So that relaxed them to a very large extent. And it was not as if we were just telling them things which were not real, they were real. The second thing was that we took the initiative to analyze the situation and then work with the political system to take a decision. And so the president actually directed that a certain amount of money, 78 million, should be put aside for this as emergency. But if you look at the context of Ghana, we had actually moved ahead. A lot of what Beatrice has talked about were already happening. We were trying to run integrated system. And thanks to the Global Fund, the Global Fund had pushed that already to look at RSSH, is a resilience system, sustainable systems for health, as part of our funding model. And therefore had what already started transitioning us from this parallel vertical project model. So a lot of the cross-cutting things were being handled by the health system, so that in case there were challenges like this, there would be nothing like a HIV standalone program. So the RSSH concept was to strengthen the health system so that the health system would take charge of the HIV program, the malaria, TB, and all that. So that transition had started, and that has to be continued. Now, when we talk about integration, we should be clear what we mean by integration, because I have been in some fora where the recipients of care are concerned about integration. They feel that integration will mean that we will de-emphasize their role and their needs, and they are swallowed up, and we will not give them that attention. And that discussion must happen for us to really agree that integration doesn't mean that the quality of your service is going to go away, but just that we are trying to make sure that we take advantage of additional resources, human resources, and all that. We have a tax sharing policy that makes it possible for every other person to take care of the needs of people living with HIV once you are oriented a little. And that has been very, very useful. But the roadmap that was developed, attributed to by Beatrice, was already in place. We had done an analysis, and together with the different partners, had decided that for Ghana, there were certain areas we needed to focus on for efficiency when it comes to even prevention. And therefore, in this period where we are transitioning, we should also be sincere to agree that, look, we ideally would have loved to do everything, but what are the critical things we need to do so that we can get impact and still continue and not, to slide back. Finally, let me say something. There's an issue about recipients of care, and we started that discussion because as a program, we have been asking the recipients of care, are you also willing to contribute to your care? Because in the past, as we've talked about catastrophic costs of, let's say, TB or HIV to the people living with HIV, and we talk about government always supporting and government always funding and domestic financing and all that. In Ghana, we're looking at health insurance, which is very good. Health insurance cuts across. Once you have subscribed to it, you get the service, everything. What we need to do now is to make sure that there's more money for that. But there was a simple question that we posed to recipients of care. Are you at any point willing to also take charge of your care? Are you willing to contribute something to your care? Because all this while we've assumed that, because of the impact of HIV on people, their livelihoods, they can't work. They cannot be, everything must be free. But we have moved forward. We've made progress. Now, you hardly find AIDS. You find people who have taken medication. They are well. They are living on like any other person. They are working. So they are empowered. So at this level of empowerment, can they also contribute? We shouldn't close the door, okay? Because it's not just about government, it's about individuals. We talk about private organizations. Individuals are private people. They can also decide that, look, I'm willing to pay for my service, provided it will be rendered to me. We need to have, some of this discussion, and then use the innovative financing mechanism like health insurance. Our president, in fact, has decided that we will uncap the limits for health insurance to free more resources, and some of these can be used to support the gap or to fill the gap. So this is what I have to add as far as how we need to go forward. Being very deliberate about targeting some private institutions, and then the communication around it. So, corporate social responsibility is very critical. We've not actually explored all those opportunities. And then the last but not the least, we shouldn't just say that because we are increased domestic funding, we've stopped the discussion and dialogue with partners. No, the partners will still be relevant. It's just that the way we engage partners must be different. We must be able to also present a case, an investment case that is very, all embracing for them, so that even though they are cutting funding, there will still be funding, because we're not going to all of us. The funding brings us together. Look, the funding from partners and all that, the fund doesn't come only as direct money. Some it comes as technical assistance. We need to benefit from all these things. But the way we go about it is just the model that must change, and the narration around it must change. There must be a more creative way of engaging our partners. And once we can make a good case, there will still be support to complement what we're doing, because it should not be an abrupt transition. It's a phased transition, and we need to do it so that people are not disadvantaged indefinitely. Thank you very much.
Thank you very much, Dr. Stephen. This actually ties into the question I want to ask Dr. Charles. Do you think that this is the moment? Is this the turning point, kind of the catalyst that we've been waiting for or needed to push more African countries towards owning the HIV response and perhaps the health systems and health programs broadly?
Thanks, Ina. Yeah, I think when you add up everything we've heard today, this does look like a genuine turning point. I think we would all agree, from some degree of dependence to moving forward with more sustainable country-led systems. And let me just give you a couple quick additional examples in addition to the excellent ones already provided by the other panelists. So I think countries are filling gaps, but they're also thinking transformationally. And I think some of the domestic financing efforts that we're hearing about are really transformational. Stephen just talked about Ghana's efforts to raise the caps and on their social health insurance plan. We know that Rwanda is, for instance, already covering about 85% of their population with their Mutuelles program. But now we're seeing Zimbabwe, that has always been a leader with their AIDS levy all the way back to 1999, expanding that, looking to expand an airtime levy that will also feed into their health programs. But they've also done a trip to Rwanda to look at the Mutuelles program, and they now intend in 2026 to launch a social health insurance program that we can hope is inclusive of people living with HIV. So you begin to see the knitting together of a domestic financing infrastructure that is more sustainable. I would just also note that I want to circle back to something Dr. Matanje said from Malawi, which we've seen what leadership does, and I think when the Malawian government came out with a circular reorienting external partners around national priorities and the national health system in a way that partners could contribute, as Stephen said, but to do so in an aligned way with national priorities was a real game changer. And I think that, as Florence pointed out, all these changes we're talking about, whether at the continental level, the national level, are best done when we can benefit from people living with HIV, their voices at the center of this, which is so incredibly inspiring, and will help, I think, all of us get this right, no matter where we're sitting. So, yeah, I think it's a time of genuine change and a genuine turning point. And despite the real challenges and crises that have been set off by some of the changes in the U.S. financing, I'm relatively optimistic. I'm very optimistic about the national leadership that we're seeing and the civil society leadership that we're seeing at this critical time.
Thank you very much for those important points, Charles. I must say that I am feeling personally a lot more optimistic after this first hour of our conversation than I did when we started. At this stage, I would like to open the question floor up for some questions. Excuse me, I'm going to be reading some of them from the comments. So if I get something a little groveled up, you will let me know. David Bryden is asking about community health workers. I'm not sure, David Bryden, if your question is country specific or if it was general. But let me read it, and then maybe I could ask Florence to address this one. So there's been some progress moving community health workers from being volunteers to being salaried. But how are the cuts in funding impacting this? Florence, is this something up your alley?
I'll do a little bit, and I think my colleagues from government will also help support the answer. I believe I will just allude to the fact that, yes, a lot of community health volunteer or work that was initially done just as a volunteer had transitioned into salaried work. But again, the reality with HIV, which probably may not exist for other community health system services, was this was vertically funded. So NGO-led sometimes and primarily not existing within the community health delivery service model. I'll use my country, Kenya, for instance. We have a community health systems delivery, which has a community health promoters situated from primary healthcare level to different sites, and that's paid for by government. And also at county level, it's negotiated differently. There are some counties for which they pay their community health workers. What we noticed, particularly between January, February, March, before the waiver sort of became active, we saw a lot of, like in some many communities, the CHWs that were going to do immunization, for instance, or malaria nets, and what they continued their work. But those that did outreaches for HIV, because they were parallel funded and that was affected by the cuts primarily, then those were not working. So I think there are many people letting go of community health workers, but particularly those that were doing a lot of work around prevention and targeting key populations who, because of various reasons, are targeted at proximate level and at community level, so outreaches, etc. Those are currently those that are highly affected at the moment. Yeah.
Ina, I could just add in, if you allow me. Yes, so thank you, Florence. Yes, thank you. So thank you indeed. As Florence said, each country or many countries have community health workers at different levels. Some were almost like employed by the implementation partners, either as expert clients or volunteers of different kinds. But I wanted to kind of put this in perspective. Maybe prior to 5, 6, 7 years ago, a lot of community health workers, proper volunteers, were really volunteers. If they were getting anything, it was maybe activity-based stipend, like whether they've gone to the facility, transport refund and stuff like that. But I remember, and I say this because I was working with an implementing partner at that time. I was in an organization that was an implementing partner. We were, from the funders, we were not questioned, but challenged that is called exploitation. So the concept of exploitation for community health workers came in, and there was kind of not force, but this influence to move volunteers into salaried staff, just like David has said. Unfortunately, that is what has led to almost a stop to all volunteer work now, because these volunteers were salaried, they were not doing, and how do we bring back the original concept? I think we should all remember that the communities, right from the beginning, prior to Global Fund, prior to PEPFAR, prior to most of these financing mechanisms, were there as volunteers, offering home-based care and all that. And truly, they shouldn't be exploited, but there was a genuine commitment for people to support their communities, to take turns to do something. But I think what the salarying of the volunteers did was to choose a few that had some sort of education. Maybe in Malawi, we call them junior certificate of examination, JCE or whatever, those that had a level of education to be involved now as staff of the implementing partners. And currently, even though as a government in Malawi, I think I remember in one meeting where there was a dialogue by the different civil society organizations with the governments. There was a commitment from Minister of Health to say when they're recruiting health surveillance assistants who are community health workers, but a different cadre is on government payroll. They are trained fully. They are not volunteers. These are a community-based cadre that is part of the public health system. So there was a commitment to make sure that when recruiting, those that have experience as community health workers should be given an opportunity because they have the skills, they have the passion, and most of them are working in their communities. Compared to the other health surveillance assistants that are employed from elsewhere, they do not even want to go and live in the communities. However, what is the current biggest challenge? The challenge is the numbers that we are recruiting on this cadre cannot match the level or the numbers of the volunteers that are out there. So it is indeed a big challenge. The funding cuts have affected the involvement of the community health workers and therefore the delivery of the services. For example, tracing. For the defaulters on treatment, for the mothers with the babies that are exposed and all that, these volunteers were helping with the tracing. Now, a lot of tracing programs have stopped because the volunteers are no longer there. Thank you.
Thanks, Beatrice. Don't go away. The next question is for you. Specifically, how will the government, the question is from Tulani, and Tulani wants to know how the government of Malawi will guarantee that the sustainability agenda remains people-centered, resources, systems, and accountability mechanisms that can tangibly strengthen service delivery and improve outcomes for those most affected.
Sorry, I was trying to see which question is that, but the question is on sustainability. How? Maybe just come back because I can't see on the chat where exactly it is. Let me just repeat it for me. Thank you.
The question is about how the government of Malawi will guarantee the sustainability agenda. How the government will guarantee that the sustainability agenda remains people-centered. Okay.
Thank you for that question. So the sustainability agenda, right from the beginning, even prior to this year, when, as I said, this whole funding landscape change has happened, the civil society was part and parcel. So we've had representation at national task force level, and our expectation was that the people that sit in that task force would be going back to their members, because we have a large network of civil society organizations. We have PLHIV, we have general civil society organizations, that network of those that are doing services. We have various levels. And much as the National Technical Working Group on Sustainability could not bring everybody, they were represented. And during the situation analysis and mapping that happened in November and early December last year, we had a deliberate effort to bring all the civil society organizations in one place to be consulted, for them to be part of the agenda. But as I said, the sustainability roadmap that was developed at the beginning or drafted at the beginning has changed its course. The biggest change now is that there is a feeling that we cannot do HIV sustainability alone, because the funding landscape change has not only affected HIV. If you look at the maternal reproductive health, maternal and newborn health services, most of them were supported by USAID, and they were the largest to be affected when the waiver came, because the waiver was not for USAID. The waiver was mostly for the CDC and other agencies. So that sustainability roadmap now is not only focusing on HIV. The sustainability roadmap is focusing on all other conditions that are donor or have been donor dependent: malaria, TB, reproductive health, and others. And it's a genuine question: how do we make sure that people are contributing to this? And I think it's a call not only from us as NAC, but especially for the Minister of Health that is leading the expanded sustainability roadmap process, to make sure that at every level we have the people, not only PLHIV, but even other civil society organizations that have interest in malaria and other conditions, to be part and parcel of what we are developing. So from that point of view, we will make sure that we bring in this point, but also to say that our networks have expanded. The religious network, their strategic plan now is not talking about AIDS action, but general action. For the civil society as well, and the Mandate Plus, they've all launched, or they're launching new strategic plans that are looking at expanded roles beyond HIV only. So we hope through these networks that are already established, they can also pull in others that were not HIV focused, but doing other work outside HIV. Thank you.
Thank you very much. Colleagues, we are quickly running out of time, so I'm going to ask you to keep your responses short. Landry, I see your hand, and actually the next question is for you. So perhaps you get your... maybe I will open the floor to you, and then we'll see if you might have addressed my question already.
No, I think just 2 points. The first one is to emphasize on the unique role that our community health workers are already playing. What we don't say enough is that on our continent, the AIDS response has set a different momentum for community health programs on the continent. The program that was driven initially by the Child Survival Agenda was elevated because people with HIV really were at the forefront of advocating for the institutionalization of community health workers. I think we moved from the volunteers to become now a community health programs. I want to emphasize that in 2017, the head of state took a bold decision looking at the health workforce crisis on the continent. It was estimated at 2.5 million, the healthcare workers' needs on the continent. The time it takes to train doctors and nurses definitely will not allow us to meet that, to bridge that gap. So they took a clear direction of travel, which was to have 2 million trained, equipped, protected, and deployed community health workers. 2024, we have now reached 1 million. Now the question is this: do we have a polyvalent community health workforce today? Because the parallel systems that colleagues, other panelists explain, HIV programs with one group of CHW, immunization with another group. When one funding stream ends, what do? So it's time for the continent, and that's the direction of Africa CDC is advocacy for having upscaling of existing community health workers to make them polyvalent, to make this part of the integration that the colleagues were talking about. The second point I really want to emphasize here is this. At the end of the day, it's going to be about how do we strengthen our primary health care system to make it more resilient. I think the voice of people living with HIV has transformed the AIDS response on the continent. The question is, how can we create similar momentum around the transformation of our primary health care? How do we bring the voice of champions like Florence to talk about primary health care transformation? Because that's the backbone of the resilient system that we need for the next shocks that definitely may happen.
Thank you very much, Dr. Landry. The following question is for Dr. Stephen, and it is from Maria Stacy. Maria says they work primarily with key populations. So who are the key populations with the greatest need for HIV prevention and treatment? So the reason that, apologies, let me just get it. How can integrated health services prevent key populations from being excluded going forward? Maria wanted to hear from Ghana and Malawi. Maria, I'm not sure we have enough time for both of them. Can I give Dr. Stephen a chance? And let's see how quickly he can answer.
Yeah, I think in our context, men who have sex with men transgender, because they have high prevalence, 48%, 26%, and then people who inject drugs, we're now estimating, and all that. But already, this approach of government-led programs is the way to go. I mean, even though Global Fund was funding a principal recipient to focus on key population, the government program was leading, was in charge. So everything that is done, that agenda is set by the government, and then they will support the PR to do its work. But I think going forward, what must happen significantly is that if it is funding, it must come through the government. Because when we face this issue of a law which was coming, against LGBT and all that. We managed to handle it smoothly, programmatically, because we led the responses and everything. Government will not view it as a separate issue if the same government is in charge. Okay, so it means that going forward, what we need to do is that whatever their priorities are must be incorporated. It must be part of the government priorities. It should not be a separate program. It must not be a standalone program. But once government takes the leadership, we can have sub-recipients who are civil society, NGOs, to be able to also complement the work by taking their part, playing their role. But it must be led by government, and that's the only way. And if you look at all the tests, the commodities, already in Ghana, the commodities government-led, and it's available to all these key populations. All right, so when we procure, government procures anybody, we procure also for key population, and that is China. So it doesn't matter. There's no discrimination already, and that integrated mechanism is the way to go. Thank you.
Thank you very much. I apologize. Thank you very much, Dr. Stephen. I must apologize for everyone who's taken the time to join us for not being able to get through more of these questions. I think that in future, the guys from the conversation, I hope you're hearing me. In future, we need one webinar to talk about financing, one webinar to talk about community programs, so that we can get through everything together. I would like to give the last couple of minutes of these webinars back to our panelists to perhaps give their closing remarks. What is your takeaway from this? What do you want us to walk away from this? Dr. Stephen, you are unmuted, so I'm going to pick on you first.
Thank you very much. I think it starts with information, data, the way we manage data, whether it's community, whether it's different populations and all that. We should make sure that we have accurate data on the issue. If there are gaps, we should be able to clearly define the gaps. And then the second thing is communicate that information very well. I think the biggest problem we're having is miscommunication, because something is said is blown out of proportion, but that must not be blown out of proportion. If we are able to make a good case to all the key leaders, politicians, and all that with the right data, technical data, people cannot close their eyes to that data. All right. And once the data is generated by a unique government-led, so that there is not there, still we have the same reporting mechanism. It takes control of everything, and then we can all take decisions based on that. So once we have a good data, accurate data, timely decision on it depends on leadership all around us. So let's continue to dialogue. Let's continue to talk like this. Let's continue to express our fears, but let's not view each other as this and they, we and they, as is always the case. Recipients of care think that these government people, they don't like us, or they have a different agenda. Government people are suspicious of also civil society, and it's a conflict. No, let's work together. And that under this particular period of our framework, we are working very close with civil society. And we have what we call the community scorecard, which is both executed with both government and the communities. So there's community-led monitoring, and there's reporting together. There's a feedback, and it's seamless, and we take the remedial actions together. All this confidence in one another that will make us achieve something significant going forward. Thank you.
Thank you very much, Dr. Stephen. Dr. Landry, over to you. Final words, final thoughts?
Thank you so much, Ina. I think this conversation, I think that's the title, right? Conversation Africa. It's more than a conversation. I think these are defining moments when we have the opportunity to reflect on the crisis, because the health cut is definitely a health financing crisis for the continent. And in front of a situation like this, we need leadership. and homegrown leadership is irreplaceable. And this is what we are seeing across our member states. And we also need the leadership to be united. And that's what we are seeing with our head of state through the African Union, calling for reinventing or reimagining health financing in this particular area. The second point is that this is also an area of opportunity. And Florence really clearly articulated that, because this is an area where innovation will spark. I think we are well aware of the recent Menakapavi as a biomedical innovation on HIV prevention. And Africa CDC is working with partners like UNAIDS and the Global Fund to make sure that those innovations do not face any barrier to reach those who need it the most. The third point is around integration. We need to have more and more solidarity in terms of initiatives. I want to highlight one here, which is linked to the triple elimination of HIV, syphilis, and hepatitis, because it's going to be about the measure of the success of overcoming this is also on the quality of life of our children, the next generation. So no child should live or should come to life with HIV, hepatitis, or syphilis when we know what to do to prevent it. And those are the critical directions that Africa CDC is leading next to our member state with our partners. Thank you.
Thank you very much. Dr. Beatrice, final thoughts from you, please.
Thank you. As we close, I'd like to call for a transition from the fragmented, externally dependent HIV prevention and treatment systems and programs to nationally led, integrated, and sustainable systems. However, this sounds good on paper, but I think to achieve this, there are some foundational shifts that are required to be made. So the first shift, as we have said, is to move from parallel programs to integrated platforms. So no HIV system and program should come as a standalone system-wise. It should be integrated within the primary health care as well as universal health coverage systems. Secondly is to move the HIV response to a shared public health responsibility, whereby the HIV should be recognized as part of routine public health service and funded by the governments as part of the routine public health system. Thirdly, to move projects, because a lot of interventions come as projects, to move from project approach to routine platform and program approach. Anything that comes, we would still need external support. We would need the philanthropic supporters, the Gates Foundation and others that are out there that may still be supporting countries to support systems, to support programs and not projects. And finally, to move from using the communities as outreach platforms, but rather to ownership, for them to own the programs, for them to lead the delivery as well as the monitoring through community-led systems. Thank you.
Thank you so much. Dr. Charles, over to you.
Thanks, Anu. I just had to come off mute there. I think what we've heard today is really extraordinary, and countries are stepping forward with courage and with incredible clarity about their direction. I think there's political will at the national level, and as Dr. Sagi has well referenced, at the regional level, that's stronger than ever before. And, having spent the last 2 decades working towards supporting our aims in the HIV epidemic, it's really encouraging to see these things coming together. And I think maybe the challenge I would put forward and a question that I really have is whether partners and donors at this time will step forward with equal clarity, equal urgency, and to spend some time listening and to spend some time thinking about how best to strategically align and to invest in the kind of response that each one of the panelists has outlined, a response that's truly sustainable, a response that doesn't leave behind people who are most marginalized and who have been stigmatized within health systems in the past, and to really demonstrate the kind of global solidarity that this moment demands. So I come away from this conversation with a lot of hope, but also let's stay together on trying to hold everyone accountable towards the things we've talked about today. Thank you so much.
Thank you very much, Dr. Charles. And finally, Florence.
Thanks, Ina. I just want to start this way in my final closing. 20 years ago this month, I tested HIV positive. And it's because I saw a big billboard with my president's face on it, asking us to go get tested, because if we need treatment, they will give it to us. I would like to close by asking everyone listening and watching, and every leader and every community member right now, let's not lose sight of the significant, great work we have done so far. Myself and many, many people globally, there are 39 million people on treatment right now, 30 million people on treatment right now. We have significantly improved coverage for HIV. There are many people living with HIV who have better lives, who are useful to our governments and our countries. It's because of all this global solidarity, our national leadership, and the incredible work of the people that are sitting in the various departments right now. Let's not lose sight of that. And let's hope that that gives us the energy to understand we are in a moment. It will require some energy in leadership, strategic objectiveness in deciding how we move into this moment to be more pragmatic and sustainable into the future. For people living with HIV, we have to embody mind shifts around our own self-care and understand how we can work with you. There are so many of us discussing what opportunities are there for some of us who can afford treatment to be able to. There are conversations we can have and we need to continue having. But let's not lose sight of the incredible work that the HIV movement has done for health in the whole world. Thanks.
Thank you so much, Florence. We really look forward to centering people most affected and living with HIV in this conversation. I think that's very important. At this stage, I would like to hand over to Adejuan Shoyinka. He's the West Africa Regional Editor for The Conversation Africa. Adejuan?
Hello, hi, Hina. Thank you very much. And I must first say thank you, Ina, especially for navigating this, helping us navigate this really interesting and I dare say enlightening conversation that we've had today. The conversation has invited us, to rethink local financing models and in response for Africa's response for HIV. It's also invited us to rethink how we model partnerships, and also invited us, especially for those of us who are journalists, flowing from what Florence said earlier on, invited us to rethink how we communicate the issues, and always remember that when we're dealing with figures and just reading out figures, we're actually talking about human beings here. And I found that very, very profound. Just as Ina, I'm also guilty of that point. And that's one major takeaway that I'm personally taking from this conversation. So at this point, on behalf of the Conversation Africa, I must say very big thank you to our audiences, people who've joined us from across the continent of Africa and from different parts of the world, and stayed true to this conversation and actually stayed engaged all through. People sent a lot of questions, some of which we couldn't even get to in the course of providing responses. We say very big thank you. Huge thank you to our panelists, starting in no particular order, from Dr. Landry Sagwe, Dr. Charles Holmes, Ms. Florence Anam, Dr. Beatrice Matanje, and Dr. Stephen Ayisiadu. Big thank you for your time. Thank you for your insight, for your expertise, and the knowledge you've shared, and both perspectives that you've shared with us today. It's been hugely enlightening. I must also say a big thank you to our partners, the Georgetown University's O'Neill Institute for National and Global Health Law. Thank you very much for collaborating with us and making this happen. Of course, the conversation does not end here. It continues. It continues on our different platforms and also on the platform of the Conversation Africa, where we'll be sharing interview series and academic reflections off the back of our discussions here today and beyond. We will also be providing links to resources as well as recording of the entire session as well. I must say really big thank you to everyone for taking our time to participate and participate effectively, especially. Thank you, and thank you for your time. Back to you, Ina.
Thank you very much, Adejuan. There's a saying that necessity is the mother of invention. And after this conversation, I'm hopeful that this crisis is the catalyst we need to reimagine the continent's HIV response and build sustainable programs and health systems in general. Thank you all for joining us and making the time to be with us. Goodbye.